Hi, I'm Kelly, a registered respiratory therapist with Blue Zone Health. Do you feel breathless much of the time? Are you unsure of how to manage your breathlessness? Is it keeping you from doing all the things that you would like to do? I'm here to help you learn to work with your healthcare team to come up with a plan that will work for you. There are lots of tools, tips, and tricks and breathing exercises that you can do now that will help you breathe easier and more effectively. I look forward to joining you on this journey and empowering you to breathe better. Welcome, everybody. Welcome back to the 2026 edition of the Cozy Lung Lounge. I'm Kelly Lewis.
Hey, guys, I'm Amy.
Hi, everybody. I'm Gina. Nice to see you back.
Nice to have everybody back. Welcome back. Before we start today's episode, we're going to talk today about COPD and we're going to talk about pulmonary hypertension. But before we get to that, I just want to remind everybody, it is not too late to get a flu shot. And it's not too late to get a measles vaccination, another dose, if you fall in the category where you might need it. And there's some not conflicting information, but just some confusing information out there about if you need a measles vaccine booster or not. And I'm reading, there's a couple of, maybe we'll put this in the chat, the links in the chat. But according to Cedars-Sinai, if you've had 2 doses of the MMR vaccine sometime between 1957 and 1968, you're considered fully vaccinated and don't need a booster. But then again, you might want to get another dose just to be safe because measles was considered eradicated in this country right around 2000. And now it is back, and now it is back again, kind of with a vengeance. And so talk to your doctor about should you have a booster MMR vaccine, because the ones that we got back when, I don't know, I'm going to say I got mine in about 1963. I'm old. And that was considered immune for life. However, with all of the resurgence of measles, that was an old vaccine. They have updated it since then. I believe it back in the 1960s, what we got was a killed vaccine, and now they have a different version. And so talk to your doctor if it's right for you to get a measles booster vaccine, especially if you live in one of the states and one of the counties that's having a big resurgence right now, which, if I'm not mistaken, is New York and Texas and a couple other places. So just check. And again, flu shots, please.
I'd like to give a little bit of a side note there. I was talking about it before, I've got a immunosuppressed teenager after a transplant. And we have not been able to get those MMR vaccines because of the live vaccine. However, they've changed those guidelines. He is now getting those catch-up doses. So it's even safe for immunosuppressed people. If you fall into that category, please talk to your doctor.
For today's topic, we are going to go ahead and dive into COPD. So that is our kind of category that we're going to fall into today. So what is COPD? I know that's kind of a big umbrella term for a few different things. So one of you guys want to explain a little bit deeper about what COPD actually is?
Sure, I'd be happy to. COPD is a set of 4 letters, and it stands for chronic obstructive pulmonary disease. And the key there is the O, the obstruction to airflow. It's also a progressive chronic lung disease that makes it hard to move air in and out of the lungs. The O and obstruction is what's causing that. And a lot of times you'll hear a couple of words also interchanged with that. COPD, chronic bronchitis, emphysema. You hear a lot of those kind of terms all interchangeable.
So essentially with COPD, the way I like to explain it, you can get the air in, but you can't get it out. And there's techniques and things you can do to help you with that. As Gina mentioned, it is an umbrella term that covers bronchitis, chronic bronchitis, and may even cover, to a degree, some asthma, because the airflow limitation is the same. Your symptoms are essentially shortness of breath, having difficulty just walking across the room, walking long distances, walking upstairs.
We've talked a lot about COPD over the first season of the Cozy Lung Lounge. We're also going to specifically talk about emphysema and chronic bronchitis in separate episodes this this season. So today we're going to talk what is the COPD umbrella, what characterizes it, and those sorts of things.
So before we go into some of kind of the pathophysiology, let's start at the kind of beginning of all of this. So what are some of the main causes of development of COPD?
There could be numerous causes. The number one cause is smoking, and that includes not just tobacco, but smoking just about anything. That can also include secondhand smoke. It could also be an environmental or occupational exposure. If you work with a lot of chemicals and fumes, things like that. It could be just if you live in a really polluted area with air pollution. It could be dust pollution. It could be anything that's in the air. And it could be genetic. There's a strain of COPD called alpha-1 antitrypsin deficiency. It's genetic. You're born with it, and you have what comes across as COPD without ever having smoked or been exposed to anything.
Around the world, one of the leading causes of COPD in women is indoor cooking fires. So here in the United States, we are pretty well ventilated. Around the world, that's not always the case. And so if you breathe in a lot of smoke, not just cigarette smoke, but any kind of smoke, that can lead to COPD.
Another risk is also repeated over and over respiratory infections growing up. So if you had RSV as a child, or you had repeated pneumonias or just chronic things going on, you have a higher risk later on in life of COPD.
We go to drag races with Right to Breathe and Joe Morrison. A lot of those mechanics and racers and fans of drag racing don't realize all the chemicals that they're exposed to, even though that they're outside. When some of these cars are doing their run-ups, or they're standing right there at the front line when a car goes to race, there's an immense amount of fumes and chemicals in the air. A lot of people around there smoke. And so going there and doing that testing and doing lung function testing on these people was a little bit of an eye-opener sometimes, with them realizing just how much they're around, and how much little things like going to an outdoor race can make a big impact on your breathing. So it's not just smoking. There's lots of different environmental stuff, whether you're cleaning the house, like Gina said, you're a cook, if you like to do NASCAR races and drag races, all those kind of things. You have to be a little bit more particular about what you're breathing in and paying attention to that kind of stuff, because it really can impact your breathing down the line.
I look around over here. We live in the desert, and there's probably 100 gardeners in our community on any given day, and not a one of them have a mask on. And they're working with those blowers, which are gas powered. So not only are they breathing in all the dust because they're blowing everything around, the exhaust from the blowers and the lawnmowers and everything else that they're using. And I just want to run around and hand out N95 masks every Monday, because I say, protect your lungs now, because later on you're going to pay for this.
You know, COPD isn't just shortness of breath. It's a long-term inflammatory process that changes how the lungs work. And it doesn't just happen overnight. You don't just get COPD. It has been happening for 20 and 30 years before you have the diagnosis.
That's one of the things that makes COPD hard to diagnose, is because so many people wait. They just say, oh, it's a little harder for me to go upstairs because I'm getting older. You know, oh, it's harder for me to exercise because I don't go to the gym as much as I used to when I was younger. And they just chalk it up to getting older and old age, when in actuality, that COPD process, which is very slow, is happening and happening and happening. It actually changed. It does what's called remodels the airways, changes your lungs and changes the way that they work. But you can't see it until it's cropped up to something where you go, okay, I can't breathe. I got to go see somebody about this.
I had a patient in recent months who was a younger one, probably 45 to 55. And she wasn't ready for COPD. That's, 10 years from now. And I had to get a little bit stern and tough with her. Like, no, your COPD is here now. You've had it for quite some time. And even though you're only 50, we've got to address the fact today and start working to manage that COPD. Now, all kinds of things lead to those diagnoses. Amy and Callie, what are the doctors looking for that causes the COPD?
looking for causes in terms of smoking, environmental factors. They're looking for the signs and symptoms of chronic exposure, unless you had A1 antitrypsin. But that progressive shortness of breath, as I mentioned, you may have a chronic cough. It may be productive, it may be dry. You may have wheezing. You may hear yourself breathing and it sounds like you're whistling, but you're not. And also you may have more frequent respiratory infections where your lungs are just irritated. And at later stages, you may start to lose some weight. And you may think, well, that's weird because I haven't exercised at all. Why am I losing weight? But you have a hard time eating because you're working so hard to breathe. And then in the end and later stages, you may have some slight color changes where you feel like your skin is a little bit more deeper in color than usual. And you may have what's called cor pulmonale, where your heart is unable to circulate the blood.
That's a lot of terminology, and I know we're going to talk about each of these diseases later. But some of the broad things that are happening in COPD, you get a lot of inflammation in there. And think about inflammation on the cut. It's very swollen. When your airways are swollen, you can't get air in and out very easily. You're going to get a lot of excess mucus creation and slugging. If your mucus is plugging your airways, you get a lot of infection risk. If you have more of the emphysema type, your air sacs are going to be destroyed a little bit. You won't be able to get oxygen in as much. All of those kinds of things could lead to hyperinflation, which is lungs than normal, than you would normally have. And so that you would find that hyperinflation. You can look at somebody barrel chested. If you've got a big round chest that's not normal for you, that's kind of an external side of hyperinflation. The doctors would look for that on pulmonary function test that CAT scans. That's because the elastic surface of the lungs has just been destroyed. It's not going to bounce back like you're used to.
So as far as testing goes, there's tests that you can take and do to tell if you have any kind of lung impairment happening. And one of those, the most reliable and accurate one, is called spirometry. And so some of you on the call, you may have done a pulmonary function test or may have done some bedside spirometry. I'll tell you straight up, it's no fun, but it's the most accurate test you can do. And what I tell people, if they don't really want to go to the doctor and start down that road, find a health fair close to you, because a lot of health fairs now are starting to invite respiratory therapists and respiratory therapy students to come and practice doing spirometry on people. So if you get one of those, you can take it to your doctor and say, okay, I'm short of breath with exercise. Here's what I did at the fair. And they can tell you from there what they'd like to do.
Hi friends, this episode of the Cozy Lung Lounge is brought to you by Hootenanny Joy, where your health and wellness take center stage. At Hootenanny Joy, we know how overwhelming it can be to stay on top of your health, especially when life gets busy or chronic illness adds challenges. That's why we've created self-study programs designed to meet you right where you are. These programs are simple, flexible, and packed with tools to help you thrive. And they come with something extra, access to a live health coach. That's me, to guide you every step of the way. Whether it's improving your sleep, learning to nourish your body, or managing stress, our programs combine proven science with practical, real-life strategies. You can work at your own pace, get the answers you need during coaching sessions, and feel confident you're making progress. Ready to take that first step? Visit hootenannyjoy.com to explore the programs and choose the one that fits your journey best. Hootenanny Joy, because your health deserves a little joy.
There's a bit of controversy in spirometry these days. It's not really controversy, just a lot of discussion, because we've got a lot of research going on with COPD. And traditionally, the instruction was defined if the amount of air you blew out was, the speed of air that you blow out is only 70% or less of the amount of air you blew out. That would signal some obstruction. There's a couple of things nowadays called pre-COPD and mechanism, which is preserved spirometry. And if you have a significant history of that exposure to smoke, but your spirometry is pretty normal, you still may have some features of COPD. It's not all the way there yet.
Some of the other testing that they do, outside of that diagnostic testing, you can think about just pulse oximetry, which is just basically where they put, most of the time it's just on your finger. Sometimes they do it on your ear if you need to, but it just checks how much oxygen you have in your blood. And then we've got the ABGs. Do you guys want to go through that one a little bit?
Well, I'll talk about ABGs. Actually, let me back up. I'll talk about pulse oximetry. So when you go to your doctor, ladies, please, pretty please, take all your nail polish off. Because the way pulse oximetry works is it's flashing a light through your finger, and it's actually looking at how much light is reflected or absorbed by your blood. And if you have pretty pink nail polish or bright red nail polish on, it really interferes. So if you're going to go and have any kind of pulse oximetry or 6-minute walk test, please, pretty please, at least take the nail polish off of one finger so that we can get an accurate reading. It's very important.
Just because the number pops up doesn't mean it's the accurate number. And so that's super important.
Now for blood gases, we don't like to do those unless we have to. But if we suspect that you have any kind of carbon dioxide retention, we will do a blood gas. Some places do them routinely. Some people will say, no, we don't need to. We can just look at pulse oximetry and your spirometry or your pulmonary function test. We can put those pieces together and decide how you're doing. But if they want one, it's a very, very accurate test.
I've got a lifelong pulmonologist mentor, Steve Arnold. Actually, today's his retirement party, so good work, Dr. Arnold. But he has a transcutaneous monitor in his office. And in that case, what he can do is put a sticker on somebody and get carbon dioxide that comes through the skin. Now, that doesn't happen very much. It's a very special place that has a transcutaneous monitor. But if you're deathly afraid of blood gases, that might be something that you could ask about.
The other tool that we have is called a symptom scale. So there's one called the CAT test, and there's one called the MMRC. And just if you ever end up taking a CAT test or an MMRC, just answer honestly. There's no right or wrong, good or bad. We're not grading you. It's just we want to figure out your level of breathlessness and how you are feeling. And it's the same thing with spirometry and pulmonary function testing. When we tell you to put that tube in your mouth and blow as hard as you can, we don't mean go. We need you to really try to get all of your air out so we can see where you are. So if you can't put very much effort into it, you're not going to get an accurate reading and an accurate result. And that doesn't help you, and it doesn't help us.
You may come into spirometry knowing your lung function is bad or you don't have much breath. And that's okay. We just want to measure what you have and nothing more, nothing less. That's the same with the 6-minute walk test. Talk about pulse oximetry. A part of a COPD assessment is walking up and down the hallway for 6 minutes or on some sort of track. You're not going to be doing it on a treadmill. It's going to be a walking test out in the hallway, measuring your oxygen. And again, I know you probably say, I can't walk 2 minutes, let alone 6 minutes. It's okay. You can speed up, slow down, rest. It all counts in those 6 minutes. So I only want to test what you're doing, not what your neighbor might be doing.
And I think another key to the 6-minute walk test is before you start, just stop for a moment and say, if I had to walk for 6 minutes, what pace would I walk at? Because running right out of the gate doesn't help you. You probably don't run anywhere anymore. So we just want to see. And if you have to stop, like Gina said, stop and rest. The clock is still ticking, but that's okay. We're trying to figure out how far can you walk in 6 minutes and how do you feel after you've done that?
We're going to measure your breathlessness, and that's all. So how short of breath are you? That's up to you. I can't tell you how short of breath you are. That's one of those signs and symptoms of COPD. Now we've figured out we have COPD. We've learned all about what causes it, and how to diagnose it. Now we need to treat and manage it. We've got a lot of good guidelines for COPD.
Most definitely.
Absolutely.
And there's quite a few different things you can do if you're diagnosed with COPD. Number one, please stop smoking, stop vaping, stop whatever you're inhaling. If you're working outside, please put a mask on. It's just prevention from now on. There's a lot of different inhalers out there. If you watch TV, there's a advertisement on every 5 minutes for this bronchodilator, that inhaler, this, that, and the other thing. Your doctor will help you figure out what's the best inhaler for you, if there is one that's good for you. And also pulmonary rehab, extremely very important. Pulmonary rehab has a terrible name. Nobody knows what it is or what it does, but it's essentially going into a group of people that look like you and breathe like you, and gradually building up your exercise tolerance, because exercise with COPD will be your best friend, I promise.
There's lots of, lifestyle modifications between exercise and stopping smoking, and maybe some diet changes in there. But, the biggest thing that we've talked about before in previous episodes is not to try to do everything all at one time. If you get diagnosed with COPD and you decide to stop smoking, start exercising, eat like only fruits and vegetables right off the bat, it's not sustainable. So making those small and intentional changes over time is how you get to that long-term goal of the smoking cessation, eating a little bit better, and just having more sustainable and consistent exercise.
Can I also just throw in, if you've just been diagnosed with COPD, please don't go on the internet and look for herbs, pills, tablets, other inhalers of heaven knows what's in these substances, nebulized things. Heaven knows what's on the internet, that people make all kinds of claims that it will help or reverse your COPD.
The old
Go ahead.
Multi came up in Facebook the other day, and this was in my circle. These are people that I knew in my local community, and I could hear them talking about putting Mullen tea drops inside a nebulizer. No. You don't want to inhale that. Now we talked about drinking Mullen tea, okay, but nebulizing it, not so much.
Yes, and be very careful of air purifiers, home scented things where you're putting drops of essential oils. I would steer clear of all of that.
Now, that's not to say we don't want to use holistic natural methods. If you know the three of us, we talk about those things all the time. Healthy eating, this can't be underestimated. Fruits and vegetables and brightly colored foods just have such amazing compounds in them that can really help your lungs.
And they tell you all different specific diets, and we've talked about diets in here, but there's better foods that are anti-inflammatory. So like Gina said, those fruits and vegetables that you're just not going to get from eating, potato chips. So I know Gina or Kelly one time said, don't eat junk food, so that's the biggest thing. And so just making sure that what you're eating is a little bit more intentional, maybe looking at what are some anti-inflammatory foods that are a little bit healthier for you, and trying to slowly incorporate those into your diet.
And I know
We
it's a
hear a
lot
lot-
of work to eat well. A lot of people say, well, I'm out and about doing this and that. And, how do I eat healthy when I'm out and about? And it's very difficult. And it's a lot of work to go to the store and buy fruits and vegetables. You got to wash them, you got to cut them up, you got to prepare them, on and on it goes. But honestly, there's a lot of meal kit companies out there now that are really going for some healthy options, organic options, clean eating options. A lot of them have 50% off for the first 2 weeks or something. So they're very affordable. And you will get all of your food groups. It will be healthy and fresh and much better for you than just reaching for that can of soup or something easy frozen. That's probably what you are doing now if you're wear yourself out when you try to cook.
There's so much buzz these days over protein and the weight loss drugs and those sorts of things. What you need to know about protein is it's going to help with your muscle mass. Keeping your muscles healthy is critical to COPD care because your lungs don't work. We need your muscles to work very efficiently to use that oxygen as it's moving around the body. So strength training is super important. Get that protein in, lift some weights. If you don't have real weights, you've got things in your pantry that will work. You've got cans of vegetables, you've got gallons of milk. I know Amy's talked about that before.
Oh, yes. You can get very creative with your exercise, doing it at home, joining an exercise class, going to the Y. There's lots of different ways that you can exercise. And like Gina said, a lot of times people don't think strength training goes hand in hand with pulmonary rehab, but it really does, because the more and more you can train those muscles to use oxygen more efficiently, the less strain that puts on your lungs when you're trying to do your daily tasks. So it can be really, really helpful. While it doesn't directly hit the lungs to do a strength workout, it can be really helpful over time, so you're not using as much oxygen.
And one of the things you'll learn in pulmonary rehab is breathing retraining. So while you're doing your strength training and while you're doing walking on the treadmill or working with weights or whatever you're doing, you're going to be practicing good breathing techniques such as pursed lip breathing, diaphragmatic breathing, things that will help you get all that air out so that the next breath you take in is clean, fresh, oxygenated air, and making room in your lungs really for those clean breaths of oxygenated air and getting rid of all that stale carbon dioxide air. And I know we went over a whole lot of information packed in this episode, so I would encourage all of you to go back and listen to some of our previous episodes where we go deeper into, for example, oxygen. We go deeper into inhalers. We go deeper into, I don't know, how many subjects have we talked about now? At least 100.
We've gone through a lot of cooking stuff too. So there's a whole
Yes.
video dedicated to cooking when you're on oxygen and cooking when you have chronic lung disease, just to make things easier for you. So like she said, check out season 1. There's lots of really helpful topics, and you can kind of look based on what the title of the episode is on and see what may be helpful for you.
I know many of you probably have other questions, about very specifics. Stay tuned because we're going to have a whole episode on bronchitis, a whole episode on emphysema, a whole episode on asthma, and so on and so forth. So keep on watching for those over the course of 2026. If you're watching us after that, they're probably out.
I think we covered a lot of ground.
Thank you, everybody, for joining us. And thank you, Kelly and Gina, for such good information. And we will see you guys in the next video all about pulmonary hypertension.
Bye, everyone.
Bye.
Living with a chronic respiratory condition doesn't mean giving up the things you love to do. At Blue Zone Health, we're here to help you breathe easier and rebuild your strength. Our online cardiopulmonary rehab program offers tailored exercises, self-management training, and expert support from certified respiratory therapists. Accessible anytime, it's designed to reduce breathlessness, improve lung function, and empower you, all while connecting you with a supportive community. Visit bluezone.health and take the first step towards stronger lungs and a healthier future. Blue Zone Health. Breathe better, live better.